Hi, good evening, everyone. I am delighted to introduce and start our webinar for tonight. We will be talking PAH, a live continuing education webcast series. But this evening in particular, we'll be focusing actually on who's in second to fifth. So we'll be talking about distinguishing PAH from other types of pulmonary hypertension. And with that, I am honored to introduce my colleague, who you'll be hearing from speaking in just a few moments, but Dr. Stephen Nathan, who is the medical director of the Advanced Lung Disease and Transplant Program at Inova Fairfax Hospital. And I am Anjali Vaidya. I am professor of medicine and co-director of the Pulmonary Hypertension, Right Heart Failure, and CTEPH program, and director of our Pulmonary Hypertension Fellowship here in Philadelphia at Temple University Hospital and School of Medicine. The learning objectives for tonight are broad. So upon completion of this activity, we are hoping that participants will be better able to recognize the different clinical presentations, pathophysiology, and treatments of groups 2 to 5 pulmonary hypertension, to classify patients with suspected pulmonary hypertension into one or more of the 5 major World Health Organization groups, to recognize and approve the approved drug therapy for each World Health Organization group, as well as their major associated risks to patient safety, and identify ongoing clinical research and future therapeutic targets for each WHO group. So with that in mind, let's jump right in. This is our very first audience poll question, and it starts very simply with: how is pulmonary hypertension defined? A, mean pulmonary pressure greater than 20 millimeters of mercury measured during right heart catheterization. B, mean pulmonary pressure greater than 25 millimeters of mercury measured during right heart catheterization. C, systolic pulmonary artery pressure greater than 40 measured during right heart catheterization. Or D, systolic pressure greater than 30 measured during right heart catheterization. Okay, our results are up. And it looks like we have a vast majority that have answered A, mean pulmonary pressure greater than 20 measured during the right heart catheterization. So that's great. That is actually our new updated definition. So congratulations to the group. We're off to a great start. pH is defined as the mean pulmonary pressure greater than or equal to 20 milligrams of mercury at rest. And while there are many causes of pulmonary hypertension, it is almost always associated with deteriorating symptoms, increased mortality, regardless of the underlying disease. Now, on the right side of the screen, you can see a nice image that kind of shows the circulatory system, really with emphasis on the right side of the heart and blood flow starting from the right atrium into the right ventricle into the pulmonary arteries. And on the top right is normal blood flow, when blood flow flows freely through that pulmonary circulation. And in pulmonary hypertension, when your mean pulmonary pressures are elevated, sometimes that leads to the blood flow being slow, and you can see somewhat restricted blood flow represented in that cartoon as well. And I often will think or like to describe pulmonary hypertension, it's increasingly common with age, and it's also, as you look at the entire heart here, it is either usually a result of heart failure or a cause of heart failure. It's a bit of a unifying concept, but really a range of underlying conditions can lead to all of these different disorders that comprise pulmonary hypertension. Now, as many of you may be familiar with, this is a nice kind of reminder of the evolution of our hemodynamic definitions over the last several years. So historically, and this dates back to the first World Symposium in Geneva in 1973, we defined pulmonary hypertension as a mean pulmonary pressure greater than or equal to 25 millimeters of mercury, pulmonary arterial hypertension being defined alongside a normal or less than 15 millimeters of mercury pulmonary arterial wedge pressure, and a pulmonary vascular resistance that was abnormal, but initially defined as being greater than or equal to 3 Wood units. So fast forward to the middle column of your screen. In 2018, we had the 6th World Symposium of Pulmonary Hypertension in Nice, and this is where the mean pulmonary pressure definition fell to 20 millimeters of mercury based on really nicely done studies looking at normal hemodynamics in healthy adults. Now, the left-sided filling pressure definition cutoff for these hemodynamic definitions has not changed. But fast forward to just sort of the last 6 months or so, the most recent European guidelines have now further modified how we might consider the cutoffs and thresholds for pulmonary arterial hypertension. So be aware that the pulmonary vascular resistance greater than 2 Wood units is now being incorporated into our definitions and cutoffs for what might define pulmonary arterial hypertension. Now, pulmonary hypertension can present with a wide range of symptoms, and one of the things that we always want to focus on is recognizing these patients earlier than what the kind of current global standards are. So early in the presentation of patients with pulmonary hypertension, the symptoms are overwhelmingly going to be dyspnea on exertion or exertional fatigue. You may have patients present with palpitations. Peripheral edema and weight gain and fluid gain is often a sign. And as things evolve, exertional presyncope and exertional syncope can really be red flags of more advanced disease. And this often correlates with exertional chest discomfort and may coincide with additional sort of pulmonary or respiratory symptoms, depending on the severity, including worsening dyspnea, perhaps some cough or additional pulmonary symptoms that are described here. The classification of pulmonary hypertension is immense. These are the 5 WHO groups that we have evolved to in our most recent classification. On the top left of your screen is pulmonary arterial hypertension. This is what includes a wide range of associated conditions such as our connective tissue disease and HIV and portal pulmonary hypertension and systemic to pulmonary shunts. We're actually not going to focus this evening on PAH because that is so often what a lot of the discussion is about. So what Dr. Nathan and I are going to do this evening is focus on the WHO groups 2 through 5, which really are the other additional groups that you can see represented here. WHO group 2 in the bottom right of your screen being pulmonary hypertension in the context of left heart disease, which I'll get into in a bit more detail shortly. WHO group 3, a very important group of pulmonary hypertension associated with lung disease, which Dr. Nathan will get into in much more detail. WHO group 4, pulmonary hypertension associated with pulmonary artery obstructions, predominantly CTEPH or chronic thromboembolic pulmonary hypertension, which I'll talk about further. And then the miscellaneous causes of pulmonary hypertension is WHO group 5, and Dr. Nathan will give us an overview of that towards the end of our sessions this evening. So here is our next audience poll question. With those groups in mind and those broad classification groups of pulmonary hypertension, which of the groups is the most prevalent? Choice A is pulmonary arterial hypertension, that's WHO group 1. Choice B is chronic thromboembolic pulmonary hypertension, that's WHO group 4. Choice C is PH associated with left heart disease, that's WHO group 2. And choice D is PH with unclear or multifactorial mechanisms, that's WHO group 5. And it looks like our results are in, and we have really a strong, overwhelming majority of folks have answered choice C, which is PH associated with left heart disease. So that is absolutely correct. And that is a nice segue into kind of our next section here. So look at this figure nicely breaks down the different WHO groups. At the top is just PH across the world. And there's a little bit of a distinction of pre-capillary versus post-capillary disease. But in the middle row, with the different cartoons, you'll see the representations of the WHO groups 1, 2, 3, 4, and 5 across the screen. So focusing in on WHO group 2 with the left heart disease, you can see this really is the most common form of pulmonary hypertension in the world, in the United States, in rural centers, academic centers, community practice, wherever you are. And we'll focus in on that in a little bit more detail, but also recognize with chronic respiratory disorders being very significant and common, that's going to be the next potentially most common associated form of pulmonary hypertension. And while we sometimes consider PAH and CTEPH as less common, it's important to emphasize that while it may be less common, both of those groups are incredibly under-recognized and underdiagnosed. So really important to pay attention to all of these different WHO groups as we think about diagnosis and working up these patients. So focusing specifically now more on PH associated with left heart disease, this is really a very important phenomenon. And amongst patients that have left heart disease, we know that if there is concomitant pulmonary hypertension and RV dysfunction, one that is frequently present, and it increases the risk of morbidity and mortality quite significantly. And as I mentioned before, of all forms of pulmonary hypertension, left heart disease, or WHO group 2, really accounts for the vast majority of cases, accounting for approximately 65 to 80% of all cases of pulmonary hypertension. And looking at it in a more refined fashion, these are the associated conditions. So no surprise, systolic left-sided heart failure is an obvious one that's not easy to kind of miss. But heart failure with preserved ejection fraction is one of the most commonly under-recognized presentations of pulmonary hypertension in the context of left heart disease. This can also include, of course, left-sided valvular diseases. I saw patients on inpatient PH rounds today that had significant mitral regurgitation, paravalvular leaks, aortic stenosis. So we do see significant left-sided valvular disease contributing to pulmonary venous hypertension. And of course, the complicated syndromes that are sometimes associated with congenital heart disease as well that can cause post-capillary pulmonary hypertension. Now, we talked about our hemodynamic definitions previously. There's a term here at the top in blue that's isolated post-capillary pulmonary hypertension. The concept here is referring to just pure pulmonary venous hypertension, meaning there's pulmonary hypertension and it is entirely on the basis of elevated left-sided filling pressures with what is defined as normal pulmonary vascular resistance. So that's sort of pure pulmonary venous hypertension. But the term CPC-PH is increasingly being used and must be recognized. And this is the combined pre- and post-capillary pulmonary hypertension. And of course, there is pulmonary hypertension with a mean pulmonary pressure greater than 20, but you have a combined abnormality of post-capillary disease with an elevated pulmonary arterial wedge pressure, but in addition to elevated pulmonary vascular resistance. And you can see, as I referred to earlier, slight nuanced changes in the definitions of what those cutoffs are for the exact values, but the concept is the same. Now, the pathophysiology of PH from left heart disease, I alluded to initially a bit. You can see on the top of the screen here, the kind of heart failure types of patients. You can have the reduced ejection fraction, the moderately reduced ejection fraction, or heart failure with preserved ejection fraction. And then again, you may have abnormalities in the aortic valve or the mitral valve being stenotic or regurgitant, in fact. And when you have these abnormalities, starting with the left side of the heart, you can see on the bottom of the screen, initially that left heart disease may be relatively controlled and you might not have pulmonary hypertension. But as those left atrial pressures start to rise and you get ongoing pulmonary venous congestion, this can lead to combined, ultimately pre-capillary and post-capillary pulmonary hypertension, where you have venous and arteriolar remodeling. And ultimately, you can get uncoupling of the right ventricle and the pulmonary artery as a result, ongoing right heart strain, and you've shifted from what was initially a pure left heart phenotype to one that is mixed left and right heart phenotype as well. And these patients can become quite complicated. So here's our next audience poll question. Which hemodynamic parameters can aid in the differentiation of PAH, that's WHO group 1, from PH due to left heart disease? Choice A is mean pulmonary pressure, pulmonary arterial wedge pressure, and pulmonary vascular resistance. Choice B is TAPSE and pulmonary vascular resistance. Choice C, cardiac index and cardiac output, or D, none of the above. All right, so we have quite a good amount of answers that have come in, and the vast majority have chosen choice A, a mean pulmonary pressure, pulmonary arterial wedge pressure, and pulmonary vascular resistance, which is correct and meant to represent the full hemodynamic profile to identify that there is left heart disease involved from that elevated pulmonary arterial wedge pressure. Now, as you may imagine, it is absolutely critical to make the differentiation between PAH and PH due to left heart disease. The management implications are profound, and things to consider that would raise your suspicion for left heart disease would correlate with risk factors for left heart disease. So often, particularly in our population, might be older patients, those that suffer from the metabolic syndrome, those that have had imaging that are consistent with left ventricular abnormalities or valvular abnormalities. And when looking at hemodynamics, we pay attention to things like, at times, the DPG, the diastolic pressure gradient, although that is being focused on a little bit less commonly these days, but the transpulmonary gradient, those two things, if they're abnormal, might give evidence for a precapillary or arterial involvement, along with that pulmonary vascular resistance. But when you start to see that that pulmonary capillary wedge pressure is elevated and abnormal, of course, that's when you have to focus more on PH due to left heart disease. Now, these things might be influenced, the physiology of this might be influenced based on diuretic management or fluid status, but the overall phenotype and physiology of a patient who has left heart disease, pulmonary hypertension, wouldn't necessarily be changed just from diuretics if you're looking at the entire clinical picture of risk factors and echo Doppler assessment, et cetera. So this takes a little bit of a deeper look into these concepts. So these are the guidelines from the European document that came out in September. On the left side column, you see various different clinical factors. And what they've done here is the first column after that is basically features that would make you think that left heart disease PH is unlikely. And on the far right, features that would make you think that left heart disease PH is in fact likely. And so no surprise, the distinction of age is part of that risk assessment, that pretest probability. The presence of left heart disease comorbidities, obesity, hypertension, dyslipidemia, diabetes, known left heart disease, no surprise. If you've had prior cardiac interventions, perhaps maybe that's coronary bypass or percutaneous intervention or valvular surgery. If you have atrial fibrillation, if you have known structural left heart disease, if you're looking at your electrocardiogram and you see that left ventricular hypertrophy or the left bundle branch block, and then the echo can be particularly helpful to predict left heart disease, pulmonary hypertension. Pay particular attention to your left atrial size as a clue, because remember, left heart disease, pulmonary hypertension by definition is pulmonary venous hypertension, which is by definition left atrial hypertension. So in chronic dyspnea, it would be virtually impossible to have pulmonary venous hypertension with a normally sized left atrium. So it's a really helpful thing to focus on. On cardiopulmonary exercise testing, if it's pure left heart disease, pulmonary hypertension, you will not have the overwhelming typical features of ventilatory inefficiency and a reduced end tidal CO2. And if you were to obtain a cardiac MRI, you would have a higher suspicion for left heart disease PH if you noted left atrial dilatation or strain on the left side of the heart, or even thickening of the left ventricular wall. Now, the therapy for left heart disease, pulmonary hypertension, no surprise, is really meant to focus on optimizing the underlying cardiac disease. The pathophysiologic sequence ranging from left-sided heart disease via the pulmonary circulation to the chronic right heart strain, whether this is at rest or with exercise, is present in many functions. But we know once you start to experience deterioration of the right heart function, in addition, the outcomes are much poorer. And this has been seen across the board, particularly with emphasis in HFpEF in particular. So it is really important, even in left heart disease, pulmonary hypertension, to pay attention to the right side of the heart to try to preserve right heart function. Diuretic is a huge part of the cornerstone of therapy. There is very limited and conflicting evidence using the use of PH-specific medical therapy in these patients. And some medications in particular, we know could be quite detrimental in this patient population and really shouldn't be indicated in PH with left heart disease. So wrapping up this component of the talk, when to refer patients with PH and left heart disease to a PH center. Really, any PAH patient should be followed by an expert center. It's a little less clear what to do with left heart disease PH patients. And the concept here is really that first focus on primarily treating the underlying left heart disease. Perhaps those patients may not then need referral to a PH center. But things that would prompt you to do so is if they have risk factors for PAH and CTEPH and their dyspnea is unexplained, if you have a low pretest probability for left heart disease PH and they have unexplained dyspnea, if you have an intermediate risk probability and known risk factors for PAH or CTEPH, if the right heart is abnormal, absolutely they should be referred. And patients that have already been optimized medically or surgically for left heart disease, but they still have persistent PH or dyspnea, absolutely should warrant referral to a center. So let's pause off of that topic for a moment. I want to introduce the next polling question here. Shifting gears, Group 3 pulmonary hypertension includes which of the following? A, chronic thromboembolic pulmonary hypertension, B, sarcoidosis, C, PH due to ILD, and D, pulmonary arterial hypertension. And I'm delighted to turn it over to my colleague, Dr. Nathan, who's going to take it for the next session.
Thank you very much, Anjali. Pleasure being with you here this evening. The correct answer is C, PH-ILD, and we'll talk a little bit more about that as we get going. So I'm going to talk about pulmonary hypertension associated with lung diseases and or hypoxemia, and that's group 3 pulmonary hypertension. This is a nice cartoon depiction of the lungs and all the various kind of disease categories that are lumped together under group 3 pulmonary hypertension. The two big ones that we're most concerned about are either obstructive lung disease, namely COPD, and restrictive lung disease, which is constituted mostly by patients with various forms of interstitial lung disease. There are over 200 different causes of interstitial lung disease. I'm not going to talk about that, but once patients have ILD and they develop fibrosis, they're all at risk of developing pulmonary hypertension. And when pulmonary hypertension does occur, they all tend to behave very similarly, meaning that the pulmonary hypertension then tends to drive outcomes rather than the nature of the underlying initial pulmonary parenchymal disorder. This is a very nice cartoon depiction taken from the recent European guidelines that Anjali mentioned, and it shows a lot of different things here. First of all, at the top, you see our two main conditions, interstitial lung disease and COPD. And crossing between that, we have the entity of combined pulmonary fibrosis and emphysema. So you have two destructive processes at the same time, and these patients are at particular risk of developing pulmonary hypertension. You see the estimated prevalence at the bottom of pulmonary hypertension, anywhere from 20 to 30%, and it really depends when you look for it. One thing that is very relevant with regards to pulmonary hypertension complicating lung disease is that the pulmonary hypertension tends to be rather mild, in some cases moderate, and in rare cases it can be severe. Here you see the estimate of severe pulmonary hypertension at around 5 to 10, and what we regard as severe pulmonary hypertension generally is an MPAP of 35 millimeters of mercury or more. And there's this gradation of when patients are limited by the lung disease, but as the pulmonary hypertension develops and starts to get more progressive, then the patients might develop a circulatory limitation to their activity level. So one of the difficulties we have is differentiating when patients might have group 1 pulmonary hypertension or pulmonary arterial hypertension versus group 3 pulmonary hypertension. And we have to look at various different things. What is the degree of their physiologic impairment? The more physiologically impaired they are, either by their obstructive disease or their restrictive lung disease, the more likely it is that they're on the group 3 spectrum of their pulmonary hypertension. If they have more preserved lung volumes, then they're more likely to be group 1. We also look at the hemodynamics, and the more severely the hemodynamics are impaired, the more likely it is to be group 1. But you can certainly have severely compromised hemodynamics in the context of group 3 pulmonary hypertension as well. One of the things that I don't think we've paid enough attention to in the past is to look at the morphology of the lung, look at the CT of the lung, because frequently the PFTs can underestimate the extent of the lung disease. And we've seen many patients who have normal lung function, FVCs north of 70, 80%. When you look at their CTs, they have really significant fibrosis or emphysematous changes. The group that this is most relevant in are the CTEPH patients, because they tend to have more normalized lung volumes. You have the emphysema, which tends to make the lung volumes bigger, and you have the ILD, which tends to make it smaller, and you can have pseudo-normalization of the PFTs. So always look at the imaging and trying to discern that. Discerning group 1 versus group 3 involves consideration of all these things, as I mentioned. Now, how do we go about treating patients who have group 3 pulmonary hypertension? First of all, the same strategy as what was mentioned with group 2 pulmonary hypertension: treat the underlying condition. Bronchodilators in obstructive disease, antifibrotics for those patients who qualify for antifibrotic therapy. Other patients might be treated with immunosuppressive therapies, for example, if they have a CTD. Of course, don't forget about oxygen, the need for non-invasive ventilation perhaps. Patients might have some obstructive sleep apnea that needs to be addressed that could be contributing to their pulmonary hypertension. And pulmonary rehab is good for everyone. Patients with not only COPD, ILD, PH, that improves their functional ability and well-being. Of course, don't forget about comorbidities, which could be contributing to their pulmonary hypertension. Like I mentioned, sleep disordered breathing, heart failure. Certainly, these patients tend to be more elderly and they could have a component of heart failure as well. I always joke that one of my favorite groups is group 10 pulmonary hypertension, a little bit of 2, some 3, a little bit of 4 and 5 as well. I think that adds up to around 10. But a lot of times these patients can have a mixed picture. There's one FDA-approved therapy for PH-ILD, was approved just over 2 years ago. We're going to come to that during the course of this talk. That's inhaled treprostinil. And aside from this, there's no strong evidence for the use of any other PAH therapies. We have all these PAH therapies approved for group 1, and it becomes very enticing to try them in other groups. And sometimes there's a risk of doing more harm than good. So the only approved therapy, as I mentioned, we'll talk a little bit more about inhaled treprostinil. Let's talk about ILD in particular. And this is a fairly recent study to the left that you can see, with patients divided into those without pulmonary hypertension, borderline pulmonary hypertension, mild pulmonary hypertension, and severe pulmonary hypertension. And what is very interesting from this is no matter how much pulmonary hypertension they have, they all follow a very similar dismal course. If you look at 24 months, the survival is less than 50%, around 40%. So even mild PH in the context of ILD has poor prognostic implications. If you look at the graph to the right, comparing ILD versus COPD, you can see the influence of pulmonary hypertension is more in ILD than it is for COPD, with the hazard ratio that's increasing as the PA pressures increase. At the bottom is what I alluded to already. You can see the green distribution of PA pressures in patients with lung disease, with most of these patients centered around 20 to 30. But once again, even mild pulmonary hypertension portends a pretty poor prognosis. Now, how do we go about deciding who may or may not have pulmonary hypertension? And there are many clues that we have that can clue us into the presence of possible underlying pulmonary hypertension. I think a big difference in lung disease is these patients, for the most part, are known. They're in the medical system. They have ILD, they have COPD, they're getting short of breath, they're getting more short of breath. When is it due to progression of the underlying lung disease versus interceding pulmonary hypertension? So we talk about so-called disproportionate shortness of breath, when patients appear to be more short of breath than what the underlying physiology would suggest. Always listen for that loud P2 heart sound. Signs of right heart failure are really late. We want to pick up pulmonary hypertension earlier, before they develop frank cor pulmonale. You can see cor pulmonale in COPD. Generally, we don't see it in ILD. Why is that? Because patients will usually die before they develop overt signs of pulmonary hypertension. So one has to be clued in to the subtle clues to the presence of pulmonary hypertension. We get PFTs as the routine management of these patients. The lower the DL, the more likely it is that the patients have pulmonary hypertension. Sometimes we look at lung volumes in relation to the DL, and the higher that ratio of FVC to DLCO ratio, the more likely it is that they have pulmonary hypertension. We get 6-minute walk tests in all of our patients, and there's a lot of information buried within the 6-minute walk that can provide further evidence of underlying pulmonary hypertension. The less their distance, the lower their SATs, the more oxygen they need, the greater the Borg dyspnea score, the lower their pulse rate recovery, the more likely it is that they have underlying pulmonary hypertension. We get imaging in all these patients, and we shouldn't only look at the parenchyma, but we also should look at other structures like the mediastinum, and we can measure the pulmonary artery segment in relation to the aorta. And when the PA is bigger than the aorta, that might be a radiographic biomarker for underlying pulmonary hypertension. Then we have our biomarkers in the BMP or the NT-proBNP, which can provide further information. And then echo is our best screening tool. It's not the way to make the diagnosis, it's the screening tool. And if you want to be certain and make a diagnosis of pulmonary hypertension, you always need a right heart cath. Sometimes even if the echo doesn't make mention of any pulmonary hypertension, especially if it's an outside echo where they haven't done necessarily their due diligence, and I'm suspicious by all these other parameters that the patient may have pulmonary hypertension, I'll still recommend a right heart cath, even if the echo doesn't suggest pulmonary hypertension. Now we're going to jump right into the INCREASE study. The INCREASE study was the pivotal phase 3 study that resulted in inhaled treprostinil being approved for PH-ILD. This was approved in March of 2021. This was the publication. This was published in the New England Journal in the same year. The primary endpoint was the 6-minute walk distance. Patients were randomized in a blinded fashion either to inhaled treprostinil 4 times a day or placebo 4 times a day. And at the end of the day, there was a 31-meter placebo-corrected difference between those treated with inhaled treprostinil versus the placebo arm, with most of this driven by improvement in the active treatment arm. This is a post-hoc analysis, and this was an abstract that was presented at CHEST a couple of years ago. And this looks at response based on dosing and showing that the higher the dose, the more likely that the patient's going to derive benefit. And this was based on clinical worsening, which is a composite endpoint shown by all these different things on the right: death, lung transplantation, decrease in the walk distance of 15%, cardiopulmonary hospitalization, or exacerbation of the underlying lung disease. So it was time to the first of these events, and clearly the higher the dose, the better the patient did. Now, when it came to writing the paper, we realized that there's a little bit of a bias here, and we corrected that for the paper, which I'll get to in a couple of slides' time. The bias here is that a lot of these events happen in the first 4 weeks. But what happens in the first 4 weeks of inhaled treprostinil? All these patients are up titrating, so by definition, they're all on low dose. So all events that happened in the first month were attributed to low dose. As you'll see, when we wrote the paper, we corrected for that because we made our time 0 4 weeks, giving patients enough time to up titrate and then analyzing them over the next 3 months for worsening events. And we'll come to that. So the study was positive based on the primary endpoint, a bunch of different secondary endpoints, but really what was the cherry on the top was the biomarker evidence that supported the clinical benefit of inhaled treprostinil. And here you can see what the NT-proBNP did over the course of the 16-week study. In the placebo arm, it went up, and in the treatment arm, it went down, implying less in the way of right ventricular stress and strain, really supportive evidence of the clinical benefits that were shown with the primary and secondary endpoints. What happened during the open label extension? After 16 weeks, everyone got converted to open label drug. And at the top, you can see that the former active treatment group maintained their 6-minute walk distance over the course of the next 52 weeks. What we were hoping for was that the placebo patients would play catch up, but they didn't, unfortunately. They did stay stable, however, between week 16 and week 52. And I think one of the messages from this is to look for it early and to start treatment early, because we want the patients to have that initial benefit, which it doesn't appear that the open label patients who were formerly on placebo really derived. At least they stayed stable though. An interesting byproduct, so to speak, from the INCREASE study was looking at the forced vital capacity, the FVC. All these patients had fibrotic interstitial lung disease. We were giving them an inhaled medication. We had to make sure there was no harm, no foul. So this was really a safety endpoint. But to our very pleasant surprise, it went directionally in favor of the group who got inhaled treprostinil, as you can see to both the left and the right. The left is the group as a whole. The right of it is a subgroup of patients with IPF. And there was a statistically significant difference at the end of 16 weeks in FVC favoring inhaled treprostinil. So there was great interest and anticipation in what would happen to the FVC once the former placebo arm got rolled over to open label inhaled treprostinil. And to everyone's pleasant surprise, the FVC actually went up, as you can see from these two graphs. The group as a whole on the left and the IPF subgroup on the right. So there's no claim at this time of inhaled treprostinil having independent antifibrotic properties. This is currently being studied in a randomized controlled trial called the TETON study, which is actively enrolling. Now, this is the paper that I mentioned where we looked at patients' outcomes after up titration of 4 weeks of therapy. And we looked at clinical change. And what we meant by clinical change was both improvement and worsening. And if you follow the graph, both A and B, different ways to look at dosing, but let's focus on the one at A to the left. Based on dosing at 4 weeks, you can see a very nice dose response in that the patients who got placebo had more worsening events, fewer clinical improvement events. And as we up the dose beyond 9 breaths 4 times a day, there was more clinical improvement in the high dose group and less clinical worsening. What do we mean by clinical improvement? Well, we defined that as a 15% increase in the walk distance accompanied by a 30% reduction in the NT-proBNP. So we used our biomarker to validate that the increase in the walk distance was a true increase. Let's talk a little bit about PH and COPD. This is obviously a much bigger population because of the prevalence of COPD. Anywhere from 1 to around 50% in those patients who are being evaluated for transplant. It's usually mild to perhaps moderate, same as what I mentioned in ILD. It has independent prognostic implications as well. There have been many different studies. Most of them have been retrospective, very few prospective studies, open label series that have suggested some benefit. There have been a couple of meta-analyses that have suggested benefit, but there's been no definitive study in PH-COPD as yet to show that using these pulmonary vasoactive agents actually works in COPD. So the principles of therapy are the same. Treat the underlying lung condition. If they're hypoxemic, correct that with supplemental oxygen. Just some more verbiage on the same topic. PDE5s have shown some benefit. ERAs haven't really shown benefit. And I think the bottom line from all of this is to treat the underlying lung condition, get your patient enrolled in a clinical trial if available, and if there's going to be any off-label use of therapy, this really should be done under the auspices at a PH center. Angelique, back to you. I believe number 4 is yours.
Yes. All right. Thank you, Stephen. That was great. So we're in the final third here for the evening. So we're going to jump right into group 4 pulmonary hypertension. This is chronic thromboembolic pulmonary hypertension, CTEPH, particular area of my interest, as many of you know. So CTEPH here, what we're talking about, pulmonary hypertension in the context of persistent lung perfusion defects despite therapeutic anticoagulation. And so this is a really unique subgroup in and of itself. Some patients that have chronic thromboembolic disease may not have pulmonary hypertension at rest, and this is just a really important footnote of semantics and pathophysiology. So those that have had PE, who are being anticoagulated for at least 3 months, who have persistent thromboembolic disease, at the very least have what we call CTED. But if they have that in addition to having developed pulmonary hypertension, that's when we can call it CTEPH. So this is an important subgroup. And as you know, it falls under WHO group 4 pulmonary hypertension. And while CTEPH is the classic diagnosis here that we'll focus in on, just as a reminder, it could include PH due to other pulmonary arterial obstructions, such as sarcoma or other mimickers. But for the purpose of this evening, we will be focusing on CTEPH. So here is your next audience poll question. How should you initially screen for CTEPH? Choice A, echo with VQ scan. Choice B, lung and cardiac MRI. Choice 3, right heart catheterization. Choice D, lung function test. Virtually everybody gave choice A, which is correct. That's echocardiography with VQ scan as the initial screening test for CTEPH. Now, diagnostic algorithms can be complex. There's a couple of key points here to focus on. So the diagnostic algorithm for patients that are symptomatic, there's the pulmonary hypertension workup. We suspect CTEPH perhaps if they've had a history of venous thromboembolism or known risk factors for venous thromboembolism. Remember that patients don't have to have a known history or known risk factors for venous thromboembolism to still develop CTEPH. That's quite common. But right at the top of diagnostic studies is going to be that perfusion imaging, the VQ scan, where you're looking for unmatched perfusion defects. And the echocardiography helps raise the suspicion for the vascular abnormality of pulmonary hypertension and the impact on the right side of the heart. You may note if the echo is normal that physiology, gas exchange testing can be helpful. We do a lot of that in our CTEPH center, invasive cardiopulmonary exercise testing, where you might note some of the gas exchange abnormalities of ventilatory inefficiency or reduced end-tidal CO2, et cetera, that would be suggestive of thromboembolic disease with exercise. So one of the most important things in the current state of the CTEPH world is that very early on, if you suspect it, all of the guidelines will tell you you have to refer not to a PH center, but specifically to a CTEPH center. And that's where the more comprehensive workup can happen. This often will include catheter-directed pulmonary angiography with digital subtraction imaging, along with the invasive right heart catheterization. And it is one of the most complex sort of integrated clinical diagnostic assessments to ultimately come to establish the diagnosis of CTEPH. And the treatment assessment, really all of the guidelines are quite consistent in this as well, that it should be done by a multidisciplinary team at a CTEPH center. So clinical presentation and initial evaluation of CTEPH, it may follow even just a single episode of a known PE or patient that gives a history of recurrent PE. The symptoms may include progressive dyspnea on exertion, perhaps hemoptysis, by the way, in the context of CTEPH, that often represents systemic to pulmonary collaterals. So that can be a clue of chronic thromboembolic disease. The right heart failure and right heart dysfunction, just like we talked about in other forms of pulmonary hypertension with dyspnea, fatigue, peripheral edema, exertional syncope or presyncope. In CTEPH, there may be a really long period of time, however, where patients may have had a known remote prior venous thromboembolism, but then they have a very long time before they come to clinical attention with signs and symptoms of CTEPH. ECG can be really helpful to pick up clues for right heart strain. That would be right axis deviation, right heart strain, incomplete right bundle branch block. Chest X-ray might show abnormalities, particularly in your right descending pulmonary artery. That can be quite prominent. The echo can show evidence. Pulmonary function tests in particular might show that reduced diffusion capacity. But it's a really important note, and I will often say, when you think about PAH and CTEPH, that if let's say you're trying to diagnose someone with PAH, I will often say they don't have PH until you have ruled out CTEPH, because the clinical presentation, the symptoms, the physical exam, and a lot of this testing can look quite identical. So the perfusion testing is very much at the top of the list. We're looking for abnormal perfusion scans. If you have a normal perfusion scan, you have done a fairly good job, not 100%, but probably greater than 95% job of ruling out CTEPH. But once you have a perfusion scan that is abnormal, then we really have to move forward and take a closer look with CT angiography. And at this point, you're already referring to a CTEPH center where we can complete the evaluation with catheter-directed pulmonary angiography and a more comprehensive clinical assessment there. So management strategy in CTEPH, the World Symposium algorithm from 2018 when we were in Nice is included here. Of course, there is absolutely lifelong anticoagulation. They emphasize, and again, an immediate assessment by an expert CTEPH team. And then really the decision for operable versus inoperable, and we're referring to pulmonary thromboendarterectomy as the treatment of choice. That assessment has to be done after referral to the expert CTEPH team, because it's a very nuanced clinical assessment, and the decision for operability depends entirely on the experience and skill and comfort level of that expert center. And so there are no clear, discrete guidelines that can be broadly applied to all centers in this manner. Now, if after a multidisciplinary expert experienced CTEPH assessment, a patient is deemed non-operable, then we may shift gears and consider intervention with balloon pulmonary angioplasty or targeted medical therapy. And note that even after these interventions, patients with CTEPH, and we follow them long-term afterwards, there may be a risk long-term of recurrent or persistent pulmonary hypertension, which warrants ongoing attention to care. Now, in the 2022 guidelines, this was the most recent European algorithm that came. They also, of course, include lifelong anticoagulation, immediate assessment by an expert multidisciplinary CTEPH team to determine operability for pulmonary thromboendarterectomy or not. And if not, again, we're going to consider balloon pulmonary angioplasty or directed balloon pulmonary angioplasty. And you can see these are all class 1 sort of guidelines for how to approach this. Now, the multimodality approaches are really quite fascinating, and I like that this image shows it in conjunction with the pulmonary circulation and the anatomic differences from very proximal occlusions to more proximal segmental to very distal microvascular disease. And you can see how surgical intervention with pulmonary thromboendarterectomy in a very experienced center, we would offer this in proximal disease and proximal segmental disease, and perhaps even in more distal segmental disease in the hands of an experienced center. But if not, though, that sort of disease may be considered for balloon pulmonary angioplasty or, again, medical therapy for CTEPH. Now, the criteria for operability, this is a huge discussion, but just sort of briefly summarized, in the varying data from global experiences, it can be ranging from about 10 to 50% of patients with CTEPH may be deemed inoperable for PTE, and it's for a wide range of reasons. It could very simply be because their thromboembolic disease is so distal. It could be related to significant comorbid risk factors of the patient, which, by the way, that also depends on the experience of the center, but certainly needs to be considered. Or it may be that the patient simply isn't motivated or interested in undergoing surgery, which sounds a bit obvious, but the immediate perioperative, postoperative recovery and safety in the ICU in these patients is very linked to patient motivation and strength and conditioning and sort of cooperation with the process of healing too. As I had mentioned, these factors of eligibility are dependent on a center's experience. There are data to support, similar to transplant, outcomes correlate with centers experienced, and that goes along with the capability of doing a distal endarterectomy as well. Now, in addition to the thromboembolic disease, remember that in CTEPH, there may be the potential for concomitant microvascular disease. And it's really important when making the assessment for operability that there is a thought process that includes, does the thromboembolic burden, is it commensurate with the degree of hemodynamic impairment and functional limitation of that patient? And we really should find some sort of commensurate association such that if we were to undertake such a big surgical intervention, that the patient would derive sufficient clinical benefit to undergo that risk. Now, as a reminder for medical therapy in CTEPH, the CHEST-1 trial, which now was a decade ago published in the New England Journal of Medicine, this looked at riociguat as a novel class and novel indication for inoperable or recurrent CTEPH. Very important, these patients were deemed inoperable by an adjudicated expert CTEPH panel. The primary endpoint here was 6-minute walk, and you can see at the end of 16 weeks a pretty dramatic improvement in the riociguat arm compared to placebo. Now, balloon pulmonary angioplasty, in the last few moments on CTEPH here, this is where we are taking balloons into the relatively smaller vessel branches. We're taking organized thrombi, and rather than removing it, we are not deploying stents, we are inflating small balloons and pushing the thrombus burden to the edges of the vessel in the lumen. It can cause local dissection of the media with thinning of the vascular walls. This leads to expansion of the lumen over time. The experience of BPA is far more limited even than PTE. The technique for this, however, really can be appropriate for patients after PTE, and we are doing that quite a bit, in fact. So balloon pulmonary angioplasty has really been a very exciting area that has potential further to benefit these patients. Now, it's much more nuanced than coronary intervention or other arterial interventions. These are tiny vessels, so the risk is much, much higher. Vascular injury with or without hemoptysis can occur from wire perforation, over-dilatation of the balloons. We use high-pressure contrast injections during the procedure. You may notice immediately during the procedure when the patient coughs, that's a red flag. They may actually have hemoptysis right there and then, immediate hypoxia, and pulmonary artery dissection can happen as a result of this. Post-balloon pulmonary angioplasty, there is risk of injury, relatively local reperfusion pulmonary edema. You can see radiographic opacities on the film. As I mentioned, you may have hemoptysis. There may be relative hypoxia. This can range from being relatively mild to really being quite severe, requiring positive pressure invasive ventilation. In some series, in large series, there have been a 5% rate of pulmonary artery perforation. Thankfully, with large volume experience, the risk of this procedure can go down. But lung injury rates really can be quite severe, which is why this is not a broadly applied intervention. So I'm going to shift it back over to Dr. Nathan here for group 5 to take us home, and then we'll take some of the questions at the end.
Thank you, Anjali. I see that there's some great questions coming in, so we'll try and finish in a timely fashion to make sure we can address those questions. Group 5, it's kind of like a wastebasket, so to speak, because many different diseases find their way to group 5, the hematologic disorders, chronic renal insufficiency. Probably the biggest one that we see, at least in our program, is sarcoid-associated pulmonary hypertension, but there are all these disparate conditions that exist under group 5. So here we come, and I believe this is probably our last question. Which of the following statements is true regarding treatment of group 5 pulmonary hypertension? Treating the underlying disorder remains standard of care. Large RCTs have been studied, not suing, but using PAH drugs. Multiple treatment modalities are available. Or D, pulmonary vasodilators are very beneficial. And it looks like most people put A, treating the underlying disorder remains the standard of care, and that would be correct. Okay, treatment, as I mentioned, treat the underlying disorder. There's nothing been shown in group 3 to definitively work. There have been some small case series and a very few randomized controlled studies in sarcoid-associated pulmonary hypertension. But what is ubiquitous to all 5 groups is once these patients develop pulmonary hypertension, it does portend a worse outcome. If there is a consideration to treat these patients with off-label therapy, then this should really be done under the guise of an expert center. Oh gosh, I jumped straight to the conclusions because I'm so anxious to get to the questions and probably should do that. So no RCTs, expert center. In conclusion, and most of this has been hammered home already, PH features progressive loss and obstruction of the pulmonary vascular bed, leading to increased MPAP, PVR, RV dysfunction, right ventricular failure. We spoke about the 5 groups. Some patients can have PH with contributions from multiple groups, as I mentioned. Deciding which group and what therapy involves a careful history-taking physical exam, and sometimes patients can be misclassified. Management of PH due to left-sided heart disease, chronic lung disease concentrates on treatment of the underlying disorder with referral to expert PH centers. Targeted pharmacologic and surgical treatments are available for patients with PAH, CTEPH, and PH-ILD, for whom early referral to a PH specialized center is highly recommended. And let's go back to the question. So I will answer the first one, which is, should all patients with an MPAP greater than 20 be treated? Therein lies a problem. We got given this new definition without any data. And what I would say is the answer to that is no. Patients who qualify by the new definition haven't been studied yet. I think for any medication that's to be given, you need to go by the study design of the clinical trial that got the medication approved. So pretty much all the clinical trials with approved medications have been based on the older definition of MPAP 25 or more with a PVR of 3 or more. Further studies in these patients that fit within the new definition need to be done before it can be recommended that every patient with an MPAP greater than 20 be treated. Anjali, I will direct the next one to you. Should we use the 3 and 4 strata risk assessments on all patients with PH or just those with group 1 PAH?
Yeah, so this strata risk assessment is intended to apply to pulmonary arterial hypertension. But I would just say that a lot of the concepts there, things that include functional class, walk distance, and a lot of the parameters of right heart performance, like right heart failure and cardiac index and BNP, it won't surprise you to note that those concepts can and should be applied in your clinical assessment, even for other groups, although they're not going to be as sort of well-defined in a risk assessment calculating tool. But I think those principles can help guide you in your clinical practice.
If you look at group 3, for example, I showed the survival curve, which is pretty dismal. So everyone's high risk just by virtue of the fact that they got pulmonary hypertension. So very high risk versus high risk, I don't know that there's much utility to discern that, at least in group 3. I'll take the next one. How do you educate or train patients to use an inhaled therapy for PH? How difficult is it for patients to inhale 4 to 8 doses per day? Sorry, just to clear up any confusion, inhaled treprostinil in particular is given 4 times a day. It's the number of breaths that we try and get the patients up to 9 breaths per sitting, 9 to 12 breaths per sitting 4 times a day. At least for the PH-ILD patients, these folks are usually pretty sick. Many of them are on oxygen. They're not going anywhere. And to use a therapy 4 times a day is really not a huge imposition on them. What's also available now is inhaled treprostinil via a dry powder inhalation formulation, which is just one actuation. It comes in different dosing sizes based on the cartridge, but the DPI is very small. It can fit in the pocket, and it's much easier and logistically much better for the patients because they can do it much easier anywhere they are 4 times a day. So that's just recently become available in about the last year or so. Anjali, the next one's for you. If a patient with CTEPH is asymptomatic, do you still recommend referral?
Yeah, so there's a few CTEPH questions here that I'm happy to address. So I would say that in some part may depend on the center. I'll speak for myself that absolutely, because the prognosis and the long-term risk in patients with CTEPH is quite significant. For example, on behalf of my program at Temple in Philadelphia, we review cases from around the country every week without having to burden the patient for the travel or for paying any cost or insurance or any of that. So for the purpose of trying to not miss potential for benefit and intervention, all you have to do is reach out and we'll obtain the scans and look over everything and to then help guide if that patient might then benefit from a visit. I see the question about are there clues on a CTA in CTEPH that may be present despite lack of obvious PA clot? Also, do you think VQ interpretations in community centers are accurate? This is a great question, and absolutely. The concept lack of obvious PA clot is the crux of a lot of our diagnostic challenges. So it takes a very trained eye to recognize chronic clot on CTA. I'd like to think that is improving somewhat, but in the grand scheme of things, that is still quite limited. But there are absolutely other clues. You might see a mosaic perfusion pattern. You might see systemic to pulmonary artery collaterals that have formed. You will see kind of irregularities of the vessel wall lining that may refer to chronic clot distally. You might see abnormalities in the pulmonary venous caliber of the return in the territories that have reduced arterial perfusion. You may see subpleural infarcts and scar material from distal disease. You will see lack of just vessel caliber altogether distally. In the contrast vessels, you'll see distal tapering. You may see linear webs. There are a lot of clues that I love finding and seeing, but I will say they are often missed. I do think that VQ interpretation, even in community centers, is going to be much more sensitive than a CTA. And so I do think that we can rely on the presence of normal versus abnormal on a VQ scan, even in community centers, to prompt getting the CTA and then sharing that CTA during the referral. And we can certainly review that. But the next question along those lines, Steve, if it's okay, I'll just kind of keep going in this train of thought. Are all PH referral centers expert in all groups of PH, or are there specific centers tailored to a specific group such as CTEPH? In other words, who should we be referring our patients to? And I think that for CTEPH, this is an important distinction. There are not enough, but still there are several wonderful pulmonary hypertension centers around our country, and thankfully more and more are being started, but CTEPH, that is not the case. And so the majority of PH centers are not CTEPH centers, and the majority of the referrals for CTEPH that we receive come from true national PH experts that do not have CTEPH programs there. And so who should you be referring your patients to? Very, very high volume CTEPH programs, of which there are very few. And I'm proud that we're one of them here at Temple, and we serve a huge part of the eastern half of the United States.
What I would say just in response to that is I wouldn't overthink it. If you have a local PH referral center, just send them there because they have their referral patterns, and they'll know who to send their patients with CTEPH to. So I think, rather than second guessing it, because there might be other workup they want to do before sending on to a CTEPH center. All right, I think we're running out of time, so I'm going to just hammer through the last two questions very quickly. How do experts define mild, moderate, severe pulmonary hypertension with respect to hemodynamics? There's no good definition. I think when you talk about mild, moderate, severe, you've got to look at the whole picture, and there are all these different scoring systems, like a reveal scoring system, to decide if the patient has more mild, moderate, or severe disease. So don't just look at the hemodynamics in terms of deciding severity. The last question, and then we'll call it a night. I appreciate everyone hanging in to the end. How do you deal with cough, sometimes noted with inhaled treprostinil? How often has that led to discontinuation? That's a real issue, especially in PH-ILD patients who can have baseline cough. But interestingly, in the INCREASE study, the placebo-corrected difference in cough was only around 10%, and the reported prevalence of cough or incidence of cough wasn't much different from the original study of inhaled treprostinil, which was done in patients with group 1 PAH. But it is real. Some patients will discontinue. There are things you can do, trial and error, take it slowly and up titrating them. You can use antitussives, hot milk, cold milk, warm water, whatever works for the patients to try and keep them on drug. But I find that taking it slowly in patients who have cough might be a way of mitigating cough and getting them up to the dosing that we would like to get them up to. All right, I can't resist the questions, because I see them still coming in. We'll make this absolutely the last one. Anjali, do you want to deal with the last one? Any data on definition and workup of exercise-induced pulmonary hypertension on stress echo?
That's a big one. I think for the sake of time, what I'll say is yes, there absolutely are data, and the most recent guidelines are worth checking out, the European guidelines. And I will just put emphasis that exercise hemodynamics are much more going to be your answer than exercise echo. But there are absolutely data to recognize exercise pH, but use cath more than echo.
With that, we'll call it an evening. I want to thank everyone for the engagement, especially the questions. Thank you for listening to us and taking time out from the end of, I'm sure, a busy day. Anjali, it's been a pleasure doing this with you. Thank you all very much. And don't forget to fill out your evaluations. Have a good evening, everyone.
Good night, everyone. Thanks, Steve.